Hi, my name's Elise, and I'm the academic coordinator for Muppets in 2025 and a BMed Sci student as well this year. So this year we've decided to do the How to Paeds presentation as a recording. If you're in rotations 1 and 3 at Metro sites, you'll also have the opportunity to watch this in person in your O week. So first of all, welcome. So in terms of what we're going to cover in the presentation today, it's divided into two different sections. So we've got the wards edition. So just speaking a little bit about placement, giving you some tips and tricks of how to make the most of it, a little bit about the logbook and assessments, a bit about the matrix, and then some tips that some of the team at Muppets think are pretty high yield and useful. In terms of content, we're just going to touch on some basics, including vital signs, history and examination, some basic management principles, looking at fluids and antibiotics, and then some ending in some more high yield tips as well. So getting straight into part one. Just in terms of a little bit of an overview of placement in classes, and this is more so applicable to metro settings and it might differ slightly with rural settings. So do speak to your clinical site administrator, or I'm sure they'll give you a rundown on that. But it's likely to consist of a variety of clinics, ward weeks, and ED shifts, and your attendance will be based on your site. So make sure to check with the email from your site's administrator. In terms of small group teaching, these are weekly sessions held either online or in person, which are usually run by a PEDS consultant, and each week we'll sort of swap through different subspecialties of PEDS. So you might have a RESP week, you might have like an ID and derm week, for example. Although don't completely rely on these to cover all of your matrix teaching, because it's usually a 2-hour session and your consultant will just sort of present on the information that they think is quite relevant, but doesn't often go into a lot of depth. Some of them might be more discussion-based than others as well. And in these sessions, you'll also present your contemporary assignment, and I'll speak a little bit more on that later. Bedside tutes are informal weekly sessions which are organised between your group and tutor. They're usually run by Paeds Reg, and it's up to your group to decide on a topic together or consent patients and parents prior to the tute to practice different histories and exams on, depending on what your group wants to do. For different tips on making the most of your PEDS placement, sign off your baby exam while you're on your nursery rotations or NICU wards if possible. This will just save yourself some stress later. ED is the perfect time to practice your histories and exams, and ED PEDS doctors are usually pretty happy for you to take the lead and report back to them as you go along. And also make the most of your Gen Peds time, because in different subspecialty rotations, you're likely to be a little bit more of an observer. However, on Gen Peds, if you're keen to do so, you can ask if there's any patients that you, by yourself or with another student, can see, and then report back at the end of the ward round, and then the team will often go and see the patient together after as well. So it's a really good learning opportunity. In terms of your small group teaching, your tutors will often highlight which conditions are very important. So order the importance of your matrix study based on this. And if you haven't had time to ask particular questions on the wards, for example, if you're on a particular subspecialty, you could also ask that during these sessions, at the end of the sessions as well. In terms of your bedside tutes, these tutors are often very, very busy people because they're reggers. So be proactive with organising the tutes and emailing your tutor. And as a group, before that week's session, decide on the topic that you want to learn throughout that session, or if you want to do some histories or exams. And make sure you go and consent these patients prior. And also give your tutor a heads up as well so they can have a think or prepare some material as well. And these sessions can also be great to sign off any unfinished logbook histories or exams if you're getting close to the end of the rotation and you have some things that are still pending. So in terms of your logbook tasks, these were our logbook tasks in 2024. So just make sure they haven't changed if you're looking at this list. But you'll have to sign off 3 histories, 2 examinations, perform a couple of admissions. You will have to measure and interpret a growth chart, perform a discharge summary, write a clinical letter, and then also your newborn OCE task as well. And we are in the midst of making a newborn OCE video just to help prepare you for that as well. In terms of where to sign these off, your histories and exams are often great to sign off on ED. So ask your supervising doctor if you can take a history and exam and present it back to them, or they might be there to witness that as well. Or if you're on your wards, ask your HMO or your reg for appropriate patients after the ward round that you can go and perform a history or exam on. And then also your bedside tutes, as I said, if you're unable to sign them off anywhere else. Your admissions and discharge summaries, I found that they churn through admissions in Gen Med, and the nursery often has a lot of discharge summaries because some babies are only coming in for a couple of days. So these can be a really great time to get these done. And also your help is usually actually really appreciated. I found anyway in nursery to get some of the discharge summaries done because often the junior doctors have a lot to churn through. Okay, so now for some nitty-gritty, the part that everybody will be quite interested in being tips and tricks for assessments on your Paeds rotation. In terms of the clinical case report, try and find yourself a patient early. If you complete this part early, you'll save yourself some stress later on, and it means that you have time as well to find a new case that ends up being not enough research in that area. Asking your HMO or reg for suitable patients can also be quite useful too. Make sure you carry some copies of the patient consent form around, because if you take a good history, you can ask for the patient, their parents' consent, and make sure you get it signed at that time. And then in terms of the actual topic, select quite a high yield topic or have a quick look at the literature in the field prior to actually getting to writing up the case report, because it will just save you from having to rewrite the case report if there ends up being not enough research in that field. In terms of your contemporary assignment, try and make it interactive if you can, because you're probably going to spend a couple of SGT sessions actually going through these. So if you present some interesting facts and case studies, you'll make it slightly a little bit more interesting for yourself and your peers. Make sure you know when you're presenting, look for an email from your site administrator and present evidence-based information, because although it's quite a chill assignment, you still want to make sure that you're not using Wikipedia if you can. And in terms of apexes, I understand that you guys are going to have your in-semester apexes and then your end-of-year apexes as well. So this will mainly be for your examination-based apexes. Using your ED and ward time to prep your examination skills can be very useful, because it can be difficult to find appropriate patients to practice on otherwise. So, for example, after your ward rounds, identifying suitable patients and consenting them, their parents, and practicing exams on them can be really useful. And for newborn exams, you can practice them on the newborn dolls that each site will probably have access to, so ask your administrator. And in terms of the apex itself, don't forget to introduce yourself to the child and parent, and then also treat the child age appropriately. Examiners do love to see you interacting positively with the parent and the child, so spend a minute or so introducing yourself and building rapport with the child prior to starting your examination. So if they're a younger child, that might be commenting on a character on their shirt, for example. And if they're an older child, you might ask about school, if they play any sport, or notice an item around the room and comment on that as well. Okay, so in terms of some resources and tricks for the PEDS matrix, I've collated a little bit of a list of resources for myself and the team at Muppets. So you'll always hear that the Royal Children's Hospital Clinical Practice Guidelines, or CPGs, are the gold standard. Pretty much always go to that first and then supplement your learning with other resources too. But they are fantastic, and the exams are going to be based off them. A little bit of a plug for the Muppet summary sheets that you can find in our Google Drive, which are usually just a more concise version of the RCH CPGs. Some of the matrix topics aren't covered by the CPG, so we've had to use additional resources too. Looking at past year's revision lectures in the Movements Drive can be useful as well for concise summaries. Children's Health Queensland actually has some great resources as well. And yeah, very high quality. Safer Care Victoria for the neonatology subspecialty. Teach Me Peds, which I think is a UK-based resource, but it also usually has really good information on clinical presentation and pathophys. If you're like me and you had a long commute to placement last year and you just wanted to save yourself a bit of study time later, you could listen to a podcast. The You're Kidding Right podcast is amazing. It is two pediatric trainees based in Victoria. So they're often referring to clinical experience at RCH and the RCH CPGs as well. There's also Master MRCP, which is British, so obviously take that into account. And AMSA MedEd also does a podcast with some pediatric-focused episodes. Ben Amberg's notes are great, very comprehensive. And there's also Medici question bank as well that you can do some practice questions. In terms of your tips and tricks, for R3 conditions, even if you don't get around to studying them, at least know the buzzwords, because past exams have been known to be very buzzword heavy for R3 conditions. And again, another plug, but if you refer to the Muppets Drive, we do have some buzzword resources. In your Gen Peds rotations, pay attention because the conditions that you'll see on these wards are the bread and butter of Peds. So, for example, bronchiolitis, febrile convulsions, gastro, etc. Knowing your antibiotics for relevant conditions can be very useful. And also you'll notice a little bit of a crossover with GP and O&G. So you'll be able to cover some matrix conditions then and save yourself doing double the work. Just to finish off the placement section, I've got some high yield tips. So for ward rounds, downloading the RCH clinical guidelines can be really useful if you've seen a patient and you just want to dust up on a particular condition. Common things will occur commonly, and you'll probably get quite sick and tired of presentations like bronchiolitis, but you'll know absolutely down pat at the end. If you're at MCH where there are lots of subspecialties, learn at least the R1 conditions prior to your weekly rotations. It'll just make your life a little bit easier when you have that 1 week on ward rounds. Midwives do lots of baby checks. So if you're struggling to get a neonatal exam signed off, let them know, and be very mindful with precautions and hand hygiene. And I think this particular tip is from one of our Muppets team members who said don't end up with scarlet fever like they did. So be very, very careful. In terms of clinics and ED, learning your pediatric history and exam and also your newborn exam prior to the rotation can be really useful. We have a really quick overview in the Muppets Drive. By the time you do an exam, you should have a good idea what is happening as well in the consult by the history. So then you can take a focus exam. Don't wake a sleeping baby. These are quite opportunistic exams. So make sure you ask when a baby is, for example, going to have a feed, and making sure that you ask for permission from both the parent or parents or guardians, and also from the team as well. And observing the child while they play can help you to get a lot of information prior to the consult, and also determine their developmental level as well, particularly if they're under 5 years of age. Okay, so moving on to part 2, which is the content edition. So I think one of the most confusing parts about getting started with PEDS can be the vital signs. Obviously, we're used to our stock standard adult ranges and we know those super well. But when we get to PEDS, it's obviously age dependent. But don't worry about memorizing those. You'll always get the reference ranges in an exam. And a little plug, but there are Muppets Vital Sign cards that you can attach to your ID badge. I think currently they're available at the MCH Department of Peds with Susan for a $2 donation, but I think we are planning to disperse those to other clinical sites as well. So in terms of a little bit of a rundown of the PEDS history now, for some tips and tricks, knowing that the history is largely the same as our standard adult histories, aside from a PED-specific component which can often be added in after the history of presenting complaint. Make sure that who you target the questions at is appropriate. So you might need to involve the parents more or less, depending on their age and developmental stage. Or with adolescents, you might ask the parents to leave the room as well. And you might have to be a little bit more investigative depending on the age of the child. For example, if they're young or nonverbal, you're going to be relying less on verbal communication and instead from the patient's presentation. So going through the PEDS specific history now, if you have a look at Ben Amberg's notes, there's a not quite family-friendly mnemonic that I'll keep out of this video recording, but can be very helpful for remembering the PEDS-specific history. But in terms of looking at birth, first of all, breaking it down into mother and baby can be a useful framework to think of it. So in terms of the mother, the antenatal course, including scans and serology, medical conditions prior to and during pregnancy, and any complications of pregnancy as well. For the baby, you want to know the gestation they were born at, because does that predispose them if they were preterm, very preterm, etc., to different developmental conditions and physical conditions as well. You want to know the birth mode. Was it a normal vaginal delivery? Was it a C-section, assisted, etc., and any birth complications as well. In terms of feeding, if it's a neonate, you want to know are they breast or formula fed or both. You want to also know about quantity, duration, and feed interval. And in older children, you want to know about any feeding aversions and any special diets as well. Like if they're vegetarian, then they might be more predisposed, obviously, to different vitamin deficiencies or nutritional deficiencies. Hydration, think of it in terms of inputs and outputs. And a very useful question to sort of ask about dehydration is, in a neonate, asking about the number of wet nappies compared to how many they usually produce a day. You want to know are their vaccinations up to date. In terms of growth, is a child meeting developmental milestones? You might want to ask about some developmental domains if the child's under 5. So, for example, how are they progressing socially? Are they interacting well with other children? How are their fine motor skills? How are their gross motor skills? How are they going cognitively, and also in terms of language as well. And you're going to get a lot of that also just by observing the child prior to taking the history. You also want to know, is a child growing appropriately, which you'll confirm later on with an examination and plotting the child's height and weights on growth charts too. And then finally, is anybody unwell, particularly if the child is presenting with, say, a fever or a focal source of infection? Has there been any recent overseas travel? Who's living at home with the child, so the social situation, and not asking, but just gathering yourself throughout the history and exam, is there any suspicions of neglect or non-accidental injury, which is very sad but necessary to think about. And then, are there any smokers at home who live with the child too? Now I'll speak a little bit about the adolescent-specific history, or the head screen, which annoyingly has a couple of E's and 3 S's in it. but tips and tricks. There's no blanket age necessarily, but you've just got to use your intuition when you're speaking to this child or adolescent. Do I think that it would be best, for example, to ask the parent or guardian to leave the room and do the screen with them? Definitely do it for all adolescents 15 plus, though, I would say. So it's really important to ask the parent or guardian when you're going to do this part of the assessment to leave the room briefly. And these questions can be quite invasive, particularly if the adolescent doesn't know you well. So make sure you try and build a little bit of rapport prior to asking the question. And also, these questions don't have to be in a specific order. So you can start sort of more gently and then ease into some of the more personal questions as well. But in terms of the screen specifically, starting with home, so asking about their social situation. So who do they live with at home? And do they feel safe at home? In terms of education, is the young person attending school? Are they having any academic, social, or behavioural difficulties that they perceive at school? And is there any bullying, and how are their friendships at school as well? Eating, so asking about the patients, how they relate to their weight and body shape. Asking more specifically about eating habits and dieting, particularly in a young person who you suspect might have an eating disorder. And menstrual history in people with a uterus as well can be super useful in determining or confirming your suspicions of an eating disorder. In terms of activities, you want to ask about any sport or hobbies, and risky activities as well, which you'll go into more so later, for example, drugs and alcohol. So asking about tobacco, alcohol, recreational drug use. And this can be quite a daunting question to ask, but a good way to frame it is, do those around you? You could start off by asking, do those around you smoke, for example? Do any of your friends smoke? And then you can ask, and have you ever tried smoking, or do you smoke? And framing it that way for each of the different substances can be really useful and a less of an interrogative way of asking. Patterns of use, if they do say that they use any of the above, and any negative consequences as well, like addiction, maybe stealing to access some of these substances. Social media use is really important. So does the young person use their smartphone or computer a lot? How does this impact their self-esteem? And how do they feel online? So are they feeling safe online? And then also asking about self-harm and suicidality. So just starting by asking about the adolescent's general mood. Have they previously had any acts or thoughts of self-harm? Do they have any current or past suicidal ideation? Any plans or previous attempts? And then any thoughts of harming others as well. And finally, assessing their sexuality. So their gender identity, any romantic relationships, any sexual experiences, and asking about safe sex as well is really important here, as well as any potential abuse, and assessing their contraceptive and STI risk if they are sexually active as well. Okay, so onto the Paeds exam now. So as you will see very soon, Paeds exams are largely the same as for adults. So for each of the different organ systems, they're quite similar, except for obviously the neonatal exam, which is a full top to toe. Examination is quite opportunistic in younger children. You have to let them take the lead. You're not going to be able to go in just a standard order like we would for adults. Building a bit of rapport prior to starting to make the child comfortable is very, very, very important in Paeds. And using age-appropriate language to explain what you're doing next. And you might want to demonstrate on, say, the teddy or the parent or guardian before repeating a particular part of the exam on a child, particularly if they're quite fearful of the exam or they're not engaging well. And you might have to involve the parent or guardian to help distract the child. So, for example, in the ENT exam, you can actually get the parent to almost bear hug the child with the child's head sideways and the parent supporting one side of the head, so that you can take a quick look in the ear that is facing towards you. In terms of the neonatal exam, I won't go through it thoroughly, but I'll just give some tips because, as I said, we do plan to put out a video. But it's a thorough top-to-toe exam that's done soon after birth to assess for any concerns that might need follow-up or further investigation. So first of all, explaining the purpose and asking the parents or parents for permission is super important so that they understand what you're doing. Asking the parent to undress the baby and performing the exam in front of parents, because sometimes that can be enough to reassure them as well. And asking about any specific concerns prior to beginning. That sort of just shows active listening as well. And then when you get to that specific part of the exam, they can feel reassured if that's normal or it can be followed up further. Making sure that you document, particularly any marks that you see on the baby, is super, super important. And then saving more invasive parts of the exam until last. So, for example, checking the baby's reflexes that might upset them, like the red eye reflex, and the Barlow and Ortolani maneuvers to check for hip dysplasia. Babies often don't like that because it involves sort of moving their hips and knees quite rapidly. So saving that until last so that you don't upset them early on is very important. Okay, so moving on to some basic management principles now. And the same basic management principles are going to apply to a lot of different conditions. And so this will be quite important for your end of year history, APEX history pluses. So first of all, considering the need for any fluid maintenance or replacement, because children are often prone to losing fluid at a much greater rate than, say, adults. And then also reassuring and educating the parents and guardian. So it can always be very useful to say that you would give a handout to the parent or guardian that you can get from the RCH website to educate the parent further. Safety netting the family is super important in pediatrics. So, for example, you might say a statement like, if symptoms X, Y, or Z present, bring the child back to ED. So pretty much any worrying symptoms that would be of concern to you, bring the child back. Sometimes observing the child for a period of time in, say, a short stay unit at ED can be very important, particularly in young children. So you might observe them, say, for 4 hours before discharging them home. And then also scheduling a follow-up as well. So that might either be with a relevant specialty team or the GP as well, sometimes if they're presented to ED and then being discharged home. So I'll just touch on some fluids basics now, because I guess in adult lands, we're all used to fluids just being hanging a 1 litre bag of normal saline. But in kids, it becomes a little bit more complex than that. And compared to adults where we'd go for IV therapy first, if oral fluids isn't enough, in kids we'll go to nasogastric therapy first before they're going to intravenous therapy. But if kids are shocked, that will mean that they need IV therapy to quickly replace the fluids as well. And fluid replacement will depend on the type of illness, whether the child needs maintenance or replacement of losses or deficits, or one or both or all. And looking at the Royal Children's Hospital clinical practice guidelines will become your pot of gold for this area as well, because they're very comprehensive and more comprehensive than what I'll go over today. But you'll probably also touch on this as well in your small group teaching, and I'm sure you'll get some impromptu teaching on this as well in Gen Med, for example. But just some basic principles. You'll hear the term maintenance fluids thrown around a lot, particularly on Gen Med. And for most children, what we call 2/3 maintenance is going to be appropriate. This is because if we give full maintenance, this can sometimes trigger syndrome of inappropriate ADH secretion. So that's why, particularly in respiratory illness, we like to keep it at 2/3 maintenance. This is following the 4-2-1 rule, which means that we give 4 mils of fluid per kilogram of body weight per hour for the first 10 kilograms of the child, 2 mils per kilo per hour for the second 10 kilograms, and 1 mil per kilo per hour after that, with a maximum of 100 mils per hour of maintenance. So, for example, if we had a child that was, say, 25 kilograms, that's going to be 4 mils per kilogram for the first 10 kilograms, so 40 mils. For those second 10 kilograms, it'll be 2 mils per kilogram, so that's 40 plus 20, so 60 so far, and then 1 mil per kilo thereafter. So then we've got 5 additional kilograms, so that'll be 5 mils. So in total for that child, they'll need 65 mils per hour. That would be full maintenance. So then would times that by 2/3 if we were wanting to do 2/3 maintenance. And then in terms of replacing deficit, so for example, if the child has gastro and they've had very profuse vomiting or diarrhea, we'll do a hydration assessment. We'll look at our skin turgor, capillary refill, mucous membranes, and pallor. And the RCH as well has a really, really great table that helps you assess severity in terms of percentage of body weight lost in fluid. And this will help to determine if you need to replace deficits and how much fluid to give as well. So this was just a bit of a brief overview, and there's definitely more to have a look at the RCH guidelines if you're wanting to find out more about fluid replacement. I apologise that this slide looks very, very hectic and overwhelming, but just to touch on some antibiotic basics, starting off just with an overview. One really, really important thing to know is that there's a super low antibiotic threshold for neonates. So if you've got a neonate that has fever, that's quite undifferentiated, they're often going to be started on prophylactic antibiotics just because the risk of not treating severe infection can be very, very dangerous. And if you speak to any of us who completed fourth year in 2024, you'll find that this tripped up a lot of us in our OSCEs. Knowing your key antibiotics for R1 conditions can be really important. So you probably don't need to know doses except for maybe very common conditions like otitis media. Like in adult land, using IV therapy for the shortest duration before switching to orals is important. And also using the RCH antibiotic CPG as an additional resource because that's very, very useful to refer to. So just now some R1 conditions and their antibiotics. First of all, with meningitis, it does depend on the age of the infant. So if they're less than 2 months, using IV benpen and cefotaxime. And if they're greater than 2 months, using IV ceftriaxone. And in all children, considering the addition of dexamethasone as well to help reduce cerebral edema. For UTIs, it depends if it is uncomplicated, so like a cystitis. So you can use oral Keflex for 5 days. Whereas if it's pyelo, you'll start out by using IV benpen and IV gent, and then likely switching to oral for a total duration of 10 to 14 days. Acute otitis media really depends on how systemically unwell this child is, because if they are greater than 6 months old or if they're systemically unwell, don't give antibiotics for 48 hours. There are also some other criteria that will be touched on in Paeds and GP as well. But if they are, say, under 6 months old and they do have signs of systemic illness, then you'll give them oral amoxicillin. And in children who you choose not to prescribe antibiotics for, it's very important to safety net them and review them at 48 hours as well. Get them back in and assess if they're deteriorating clinically, then you'll prescribe antibiotics. Pneumonia is quite similar to adults in terms of if it's mild illness, you're going to give oral amoxicillin. Moderate or severe, if they're tolerating orals, you can give oral amoxicillin. Otherwise, IV Fluclox and ceftriaxone. For group A strep infections, there's also criteria here about when to give antibiotics. But if the child is greater than 4 years old and they have features of group A strep infection, and they're in the high risk group for rheumatic fever, so they might be an Indigenous Australian, they might be Maori or Pacific Islander, they might have a personal or family history of rheumatic fever or rheumatic heart disease, or they might be immunosuppressed, or they might have supportive complications as well. You want to give them oral phenoxymethylpenicillin for 10 days or penicillin V. For impetigo, it depends if it's localized or diffuse. If it's localized impetigo, they're going to have topical mupirocin ointment for 5 days, otherwise oral Keflex. Septic arthritis depends on the age of the child, because if they're under 4 years, they're more susceptible to an organism called Kingella kingae. So you want to give IV cefazolin to cover that. However, if they're over 4 years old, you can give IV Fluclox because it's a lot more unlikely that Kingella kingae is a causative organism. Total therapy is usually about 3 weeks, and they're also going to need surgical drainage as well. Osteomyelitis is the same antibiotics as well, and 4 weeks of total therapy usually. And then for septicemia, it again is different depending on if the infant's less than 2 months. You're going to give IV benpen and IV cefataxime. If they're greater than 2 months, you're going to give IV Fluclox and IV ceftriaxone. And just to finish off, I'm going to do 3 rapid-fire introductions into very high-yield topics that you're probably going to be sick of by the end of your PEDS rotation. So starting with bronchiolitis, it's a viral lower respiratory tract infection, which is most commonly caused by respiratory syncytial virus or RSV, which generally affects children less than 12 months of age. So bronchioles are the small airways that have about a 2 millimeter diameter. So there's much greater resistance to flow than in, for example, our bronchi. So pretty much the pathophys is that there's mucus edema and increased cells in these bronchioles, which leads to hyperinflation of the lungs, increased airway resistance, atelectasis, and also a ventilation perfusion mismatch. And something you'll hear about quite commonly is viral-induced wheeze, which is a condition that usually affects children over 12 months. However, this actually involves bronchospasm, so it's usually responsive to salbutamol, whereas bronchiolitis isn't because it doesn't involve that same mechanism. And there's a very good Don't Forget the Bubbles resource as well. If you look up Don't Forget the Bubbles Bronchiolitis Facilitators Guide, that has some really useful information that actually helped me understand the difference between viral-induced wheeze and why that does respond to salbutamol versus bronchiolitis. In terms of clinical features, on history, when you speak to the parents, they'll often say that there was a chrysal prodrome, or they won't say that, but they'll describe runny nose, irritability in their infant, and then the infant might develop a cough, fever, difficulty feeding. They might have apneic episodes and be quite irritable as well. On exam, they're going to be tachypneic. They might be using their accessory muscles. When you auscultate the lungs, you'll find that there's usually a bilateral wheeze and fine creps. You'll also measure their oxygen sats, and if they're hypoxic, this will help you to determine the disease severity. So on the RCH website, there's a really good table that has all of these different findings and helps you to determine between if it's mild, moderate, or severe disease, which will then inform your management. So I guess the the main principles of management are, first of all, assessing the respiratory status. So if the child's oxygen sats are less than 90, you often give them low flow nasal prongs, so 2 liters per minute, and do hourly OBS and monitor the response to oxygen therapy. You might have to consider high flow nasal prongs if they're not responding, or CPAP in very severe disease. If their oxygen sats are more than 90, they can be discharged home with a review with their GP or a rapid review clinic. You could consider a period of observation, say in the short stay unit of the ED as well. In terms of assessing the hydration status, you're most likely going to commence nasogastric feeds at 2/3 maintenance, as we spoke before, if you determine that their oral intake is less than 50% or if they appear clinically dehydrated. Other important principles of management are small frequent feeds, because the infant might have trouble feeding. So to ensure that they're still getting adequate fluids, it might be useful to reduce the space between feeds, reduce timing between feeds, but they might be for reduced duration. And also handling the child minimally as well, to prevent them from becoming more irritable and then more hypoxic. So for the second of our rapid fire topics, we're speaking about gastroesophageal reflux, and I'll also speak a little bit about gastroesophageal reflux disease, because it's really important to differentiate between these two conditions, because while GORE, so gastroesophageal reflux, is incredibly common, so 40% of infants often have it. It's when the gastric contents pass into the esophagus, but usually is asymptomatic. So they might have vomiting or positing, but they won't have some of the symptoms of GORD that I'll speak about, and GORD is a lot less common. So in GORD, you've often got a low tone of the lower esophageal sphincter, and so then you have uncontrolled reflex of the stomach contents. And often these children will have associated conditions like a neuromuscular condition, for example. In terms of clinical features, so differentiating between GORE and GORD, asking about the following can help you pick the difference. So is there any distress, like excessive crying or back arching when the infant is vomiting? Are there any feeding difficulties like gagging or choking? Does the infant have a chronic cough? When you've plotted their heights and weight, or their length and weight on the growth charts, is there any faltering growth or slow weight gain? And any aspiration as well. In terms of examination, you want to assess the baby's hydration status, particularly if they've been vomiting lots, if there's any signs of malnutrition, and also doing that growth chart assessment, as we said. In terms of management, if it's likely simple GORE or gastroesophageal reflux, reassuring the parents is super important, and you can provide them education like feeding position advice, but just reassuring them that it will get better on its own and there's no actual treatment for it. But if GORD is likely, you've got to refer to a paediatrician. And sometimes you might consider a cow's milk protein allergy first of all, because this is often more common. So then often pediatricians will recommend a 2-week trial of excluding cow's milk. So that would be from the mother's diet as well if they're breastfeeding. And if there's no change, then there'll be a 4-week trial of a PPI, like a meprazole, and trialing the infant off this periodically, because obviously you don't want the infant to remain on a PPI long term. And the final rapid fire topic is febrile convulsions in the neuro section of the matrix. So in terms of an introduction, it is brief generalized seizures associated with a febrile illness, but there's an absence of any central neurosystem infection or a past history of afebrile seizures. and is usually due to simple viral illnesses like respiratory tract infections. And it occurs in 3% of healthy children and usually between 6 months and 6 years. But it's very, very important because it is a clinical diagnosis to exclude sinister causes of fever, particularly neonates and young infants, before labeling it as a simple febrile convulsion. So if you've got a neonate and you can't find a source of fever, super important to investigate this further. Find out why is there a fever in the first place, because yes, that might be causing the convulsion, but you need to treat that because it could be something really serious like meningitis. So in terms of clinical features, so they can be classified into simple febrile seizures and complex febrile seizures. So for simple febrile seizures, you'll have fever and all of the following. So it'll be a generalized tonic-clonic seizure that lasts for less than 15 minutes, and the child has complete recovery within the hour. And it doesn't recur within the same illness. So they'll just have one febrile seizure at some point and then not again during that illness. In terms of complex febrile seizures, you'll have fever and any of the following. Any focal features lasting more than 15 minutes. There's incomplete recovery within the hour, and they might recur within the same illness as well. And in terms of an assessment, as I spoke about before, you really want to pinpoint where is the source of the fever, and you need to treat that as well. And some of the following features make a simple febrile seizure unlikely if the child is less than 6 months or greater than 6 years. There's any features of complex febrile seizures, as I said. If the child's had a previous afebrile seizure, because then you need to be thinking of epilepsy disorders. If the child has a progressive neurological condition, or if there's any developmental delay or regression as well. So in terms of management, first of all, the principles of seizure first aid. So obviously your doctor's A, B, C, D, E, and not restraining the child as well. Removing dangerous objects, and also timing the seizure and observing until it's been more than 5 minutes too. And then managing the cause of the fever is super important. And Panadol and Nurofen will only treat the fever itself, just as a reminder, and any pain. So you actually need to manage the cause of the fever. So for example, if it was a pneumonia, you need to manage that with antibiotics. So don't forget about the cause of the fever. And you might consider consulting Paeds if the seizures can't be controlled, if it's a complex febrile seizure, if the child is clinically unwell, if you have concern regarding the nature of febrile illness, for example, that it's meningitis, or if the child's having frequent seizures as well. So thank you for sticking around if you've made it to the end. In terms of if you have any questions, we're going to set up a link that will run throughout the year where you guys can leave us questions and we can go through and answer them. So keep on checking back on there and have a look on there before you submit any questions as well, just in case somebody's already asked that and it's been answered. And keep up to date with us on social media, on our Facebook and Instagram is where we often post about our events and when different resources are released as well. Make sure you check out the Muppets Google Drive folder as well. But best of luck for fourth year. You guys will smash it. And best of luck for your Paeds rotation as well. Thank you.